Thank you very much, Elio. Thank you very much for the invitation. Good evening, ladies and gentlemen. You probably know the painting which is named Self-Portrait during the Spanish flu, where Edvard Munch painted itself very tired, very ill, lying in a chair with sad colors. But I've chosen another one, which is probably less known, which is called Self-Portrait After Spanish Flu, where clearly Munch feels better, there are warmest color, and this is a beacon of hope in the field of respiratory infection. My links of interest, I will briefly present a study that will begin, I hope, at the end of this year, for which I obtained financial help from Pfizer and Peckel and Aerogen. And I also had received some consultant fees for Aridis. So we have this study that you probably know. It's demonstrated that early administration of small dose of hydrocortisone for a short period improves survival in patients admitted to the ICU for severe community-acquired pneumonia and decrease the need for invasive mechanical ventilation for patients non-invasively mechanically ventilated at inclusion, and decrease the need for vasopressor for patients not requiring vasopressor at baseline, and is well tolerated. Please note that there are 4 keywords, to my opinion: small dose, early, short-term, and hydrocortisone. I'm not sure that all corticosteroids are equivalent. Perhaps this benefit is partially related to the mineralocorticoid of hydrocortisone. Perhaps there are small pharmacodynamics and pharmacokinetics discrepancy between all corticosteroids. So to date, this has only been demonstrated with hydrocortisone. So, okay, but please look at this forest plot. That is analysis of subgroups with D28 mortality as an outcome. And it suggests that the benefit is observed in not medically ventilated patients, in patients without isolated pathogen, in patients in older patients, more than 65 years, in women and not in men, in patients with CRP more than 15 milligrams per deciliter. But please note that none of the p-value for interaction reach statistical significance. So we cannot conclude on this point because we have a lack of power. So to advance on this point, I think that we need to make another meta-analysis once again with analysis of individual patient data, and we're in the process to obtain funding for realize this, and most of investigators of previous trial on CAP, but also from trials from septic shock, and we will analyze patients where septic shock is due to respiratory infection. I've agreed to participate in this meta-analysis. The second point, as nicely demonstrated some minutes ago by Grant, this was Cape Cod was intensivist designed trial, so we didn't plan, unfortunately, long-term follow-up of the patient. But like the first patient have been included at the end of October 2015, the last one at the beginning of March 2020. The study was recently published because the analysis was postponed due to the COVID pandemics. But so we are now in the process to contact patients again, to contact physicians again, to obtain data about cardiovascular morbidity, long-term cardiovascular morbidity, to test the hypothesis that treating inflammation at the beginning of the disease could perhaps improve long-term morbidity. It will be a nice challenge. The third point, mechanism of action have to be investigated, and we have collected blood samples at baseline at day 3 and day 7 of evolution, but right now we don't have analyzed them, so I have no data. The fourth point, it's like Giulio explained a few minutes ago, patients without pathogen identified, that means in this study more than 45%, and perhaps are patients with viral infection. That is a representation of different germs, different pathogens observed in this study. Very classical ones, the leader is Streptococcus pneumoniae, but most of the patients have bacterial that are identified, a few virus. But we don't standardize exploration of the pathogen. We just recommend to the investigators to test for influenza, because influenza was non-inclusion criteria for safety concern. We will discuss this on the next slide. And we have identified a very few amount of virus, and probably a large part of the patient without pathogen identified were patients with viral infection. Steroid and beta-2 agonist in acute respiratory failure. But so our aim is to demonstrate that nebulization of beta-2 agonist and corticosteroid in patients breathing spontaneously with high-flow nasal cannula could decrease treatment failures that will be defined by death or tracheal intubation during the 2 weeks following the beginning of treatment. So for intubation, the rate is estimated to be 40%, and we want to demonstrate that we are able to decrease it to 30%. So of course we will of course standardize intubation criteria, because the difficulty with such a study is that intubation is not made on the same criteria from an investigator to another. So we will standardize intubation criteria, and basically we will randomize patients with a stratification on the use of systemic corticosteroid or not. The study was planned before we have the result of the Cape Cod trial. So of course, probably a high number of patients will receive systemic corticosteroid. We will administer salbutamol and budesonide 4 times a day. We have planned to include a total 12 patients in this study. Okay.
Yeah, thank you very much, and congratulations for the great study, which I think will change practice, of course. So 2 questions regarding that study and 1 question regarding the next study. The 2 questions would be in the placebo group. I noticed that about 30% had some kind of obstructive lung disease. So could this be something of the treatment effect? I mean, I noticed there was no hypercapnic lung failure in the trial, but 30% of obstructive lung disease on placebo might be a lot. And regarding CV events, I only could find some cardiovascular events in the adverse events table in the supplement. So did you check for cardiovascular events during the acute phase of the study regularly by any protocol, or did you just not do this? And regarding the next trial, I mean, most cases of acute respiratory failure necessitating intubation in the next phase, maybe after your trial might have IV hydrocortisone. So how just do you want to get the assigned target trial?
Okay, so the first question was about COPD patients. I mean, yeah, we have conducted a sensitivity analysis with excluding patients with COPD or asthma, and the result was the same. So we can conclude this is not the fact. The second question was
CV events in the acute phase of the study.
We focus on hospital-acquired infection, and we did not show any difference. We focused on gastrointestinal bleeding. Was very rare, and we didn't show any difference. And we focused on hyperglycemia, and we demonstrate that there was high number of patients requiring insulin in the hydrocortisone group with high amount of insulin. We didn't focus of cardiovascular event during hospitalization. We are only the pharmacovigilance data about the study. We didn't show any difference, but of course, this is not specifically observed. And your question about the next study was, yes, of course, most of patients—
How to ensure enrollment if many patients will have hydrocortisone because of your data.
I agree. I agree. We designed it before, and we funded it before the results of the CAPED study, but I agree. So the question is about the role of beta-2 agonists and perhaps about the addition of inhaled corticosteroids, but I know that most of patients will have corticosteroids. Hydrocortisone. Now, I agree with the fact that continuous infusion is not based on a high level of evidence. It was based on our experience in septic shock when we used continuous infusion. So we planned the same scheme of administration. But on in the ESCAPE trial with methylprednisolone use also continuous infusion. But okay, when we designed the study, it was supposed that perhaps the level of hyperglycemia was more regulated with continuous infusion, but there are little data about that point. I totally agree. The same is true for we tapered progressively the dose of hydrocortisone, and I'm not sure this is, for a short time of administration, I'm not sure this is important.
Yes.
Yes, congratulations. I wanted to clarify your practices in France. About all of these people were defined as severe because they were in the ICU, but if I remember correctly, only about 20% were intubated and mechanically ventilated, and not many originally on pressors. So what are the criteria for ICU admission in France? Because it seemed like not all those patients would end up in the ICU in the United States.
Well, 44 patients were mechanically ventilated. Of course, we excluded patients with septic shock, and the patient with norepinephrine were probably a small proportion of septic shock patients, but the other one were patients who bad tolerance to mechanical ventilation with high PEEP level. Your question is about the practice in France. So the study was published 2 months ago. At this time, I'm not sure that colleagues use hydrocortisone, but I hope they will.
But we partially discussed that because the idea for this, since these patients are in the ICU, you mentioned to me that you can able to control the glycemia with insulin, and the question was, is this type of patient were to be on the floor, we may have a challenge with the glucose. But then Mike said that some of these patients that were in ICU in France, in the United States will be with a little bit of oxygen, you still may be probably on the floor.
Okay, we include only patients with mechanical ventilation or high flow nasal cannula, to my opinion. So patient we have to be into the ICU, and patient with a few months, 14% of patients with oxygen therapy via non-rebreathing mask, but with high level of oxygen and PF ratio less than 3. And to my opinion, those patients have to be admitted into an ICU or either intermediate care unit, but not in general ward.
Any other, why do you think that the only survivors for steroids are females and the males are going to die regardless? What is going on with the females that respond so well to steroids and not the males? What do you think that the sex difference, different, that females move I mean, great survival, and males is just chance, or do you think that there's something on the because again there's this concept that the immune response and the inflammatory response to infections, to vaccines in females is completely different to males, and some people say that probably infectious diseases should be 2 chapters, one for females, one for males, and then in your study it's almost like females survived with the help of hydrocortisone and males Nothing. Well, what do you think that?
I don't know, but the subgroup analysis suggests that perhaps there is an effect in women and not in men. This is not statistically significant. The second point, in the ESCAPE study by Meduri, is negative with methylprednisolone. But one of the difference between both studies is a proportion of women that are included, because in the veterans study, there are only 3.6% of women and 30.6% in the Cape Cod trial, more representative of the population of patients admitted to intensive care unit for severe community-acquired pneumonia. There's another representation of men. It's not the case in general ward, but in ICU, this is usual. So, okay, but I have no explanation. In the a post-hoc analysis of the ANZIX trial on hydrocortisone in septic shock, they suggest there is perhaps a benefit in men, nor in women. But so at this time, maybe the explanation.
Yeah. And I noticed that you alluded that you plan to study steroids and influenza. At this moment, since there is a lot of observational studies say that steroids in influenza may be a bad outcome, but there is a small prospective study that may be the opposite. At this moment, do you think that there's an equipoise that should, what happened in your institution? You are still looking for influenza not to use steroids, or you think that you don't look for influenza, give hydrocortisone? What would be, at this moment, your approach to the influenza story?
At this time, we look for influenza, and we did not administer corticosteroids in this case. But I don't know what steps are to be done. Perhaps animal study. I don't know if there is an adequate animal models to investigate this point. But I'm sure that this is not definitive. And perhaps in some years we will change our point of view. But at this time, I think it's difficult to administer corticosteroids in patients with influenza, except in a trial.
Okay. Very good. Any other comments or questions? Yes.
I was interested in the prevalence of strep pneumonia in your population. So I was wondering what the practice is for sampling. You know, does everyone in the ICU classically get sputum cultures? Are they good samples? Or is it just, you know, clinical judgment?
Oh, I'm not sure that clinical judgment is adequate in this case. So I think when patients are in the ICU and either mechanically ventilated or profoundly hypoxemic, they need to receive hydrocortisone. Perhaps one exclusion is patient with immunodeficit, because we include a few proportion of patients that were immunocompromised. So we have no response in this subpopulation.
Now, understanding your study in all the ICUs in France, the microbiological work was a standard of practice. There was a standard of practice. People were getting regular culture. There was nothing special to find pathogens. It was just sputum culture, blood cultures,
yes,
urinary antigen.
Yes, urinary antigen, blood cultures.
Yeah, standard
and
practice.
sputum cultures. Yeah. And for patient mechanically ventilated, of course, profound. Yeah.
Very good. Any other comments or questions? Thank you very much.
Thank you very much, Tom.
Thank you.